All right, everyone. In the interest of time, I'll go ahead and get started with some housekeeping. Good afternoon. On behalf of the ACCP Transplant PRN's Programming Committee, welcome to the second of our Match Madness webinar series. My name is Kayla, and I'm one of the abdominal transplant pharmacists at Massachusetts General Hospital and the current chair of the Programming Committee. It's my pleasure to moderate today's webinar entitled ABO Incompatibility, Challenging the Paradigm in Living Donor Kidney Transplantation. We are honored to have Dr. Rachel Christensen serve as our webinar presenter today. Dr. Christensen completed pharmacy school at Wayne State University in Detroit. She then completed her PGY1 at the University of Illinois Chicago College of Pharmacy and is currently the transplant PGY2 at the University of Illinois Chicago College of Pharmacy. We are so grateful for her willingness to present to us today. For our audience members, please ensure that your microphone stays muted for the duration of the presentation. As a reminder, your mute button is in the bottom left-hand portion of the screen. If for any reason you have a question, please feel free to submit your question using the chat function directly to myself as the moderator under the TXP PRN name. We will review all questions at the completion of the presentation. Today's webinar will be posted on YouTube after the CE window closes, which will be approximately 11 days from now. And if you experience any technical difficulties that are not fixed by logging out and back in, please make the moderator aware using the chat function. We will be taking attendance today, and we'll send out an email following the presentation with CE instructions that will require you registering for an account via Rush if you have not done so yet. And without further ado, let's let Rachel begin our webinar.
Thank you for that introduction. So you already mentioned the title. I'll be talking about ABO incompatibility today. This is a topic that I chose to present for my seminar, so I'm happy to present it here as well. I wanted to learn more about this topic since I know practice can vary a lot by center to center and all across the world. All right, so I have no relevant financial conflicts of interest in relation to this activity to disclose. However, I will be discussing several off-label uses of pharmacotherapy throughout this presentation. So the objectives of this presentation are to review the history of ABO incompatible kidney transplantation and its potential impact on increasing access to transplantation. Second, to explain the pathophysiology of antibody-mediated rejection and accommodation in the setting of ABO incompatible kidney transplantation. And third, to summarize current evidence of the use of immunosuppression strategies for ABO incompatible kidney transplantation. So first, I'll be discussing a little bit of background info. So there are 4 blood types that exist in humans, which include A, B, AB, and O. And this means that those blood groups have the corresponding antigens on their red blood cells. So blood group A has group A antigen, B has B, blood group AB has both A and B antigens, and then blood group O does not have any antigens on their red blood cells. Blood groups A and B have antibodies against the alternative blood type. So blood group A has antibodies against blood type B and vice versa. These antibodies are also often referred to as isoglutenins, so that's what I may be referring to them throughout the presentation as well. Group AB does not have any antibodies against any other blood groups, so therefore is the universal recipient. And those who have blood group O have antibodies against both A and B, so they can only receive products or grafts from blood group O donors. And since they do not have any antigens on their red blood cells or tissues, they are therefore considered the universal donor. Most common blood types in the United States are type A, which makes up 40% of the population, and blood group O, which makes up for 45% of the US population. So just as an example, those who have blood group A can receive graft from a donor with blood group A or O, but their antibodies or isoglutenins would attack a donor from blood group B or blood group AB. So ABO incompatibility has historically been an absolute contraindication to proceeding with deceased donor kidney transplantation, and this remains true today. ABO incompatible kidney transplantation is only a modality for living donation. I'll discuss more about that later. Over 20% of donors are considered immunologically incompatible due to either ABO systems between the donor and recipients. So that's something to keep in mind. The number of deceased donor kidney transplants annually has been steadily increasing. However, the number of living donor kidney transplants started to decrease in 2020 due to the pandemic, slightly recovered in 2021. However, we have not yet seen an increase in living donation to the extent that we have seen with deceased donation. So now this presents the question, how can we increase living donation? So there are several options to increase living donation. So kidney paired donation and kidney swaps can utilize more living donors that would otherwise be incompatible or unable to donate to their loved ones due to incompatibility in the ABO blood groups or due to HLA antibodies. These swap procedures can carry a lot of logistical considerations, such as if the living donor declines at the last minute, if there's geographical limitations, cost, coordination, especially if there's more than one center involved or surgical team involved. And then these logistical considerations may change based off of several different factors. And then with the utilization of ABO incompatible donors, living donation could potentially be increased up to 30%. And just for frame of reference, there was about 6,000 living donations in 2021. So that could be another potentially 1,200 living donors we could utilize if we use more ABO incompatible donors. So with concurrent protocols that we have for desensitization now, as many as 90% of patients who have a donor that is ABO incompatible could be desensitized and transplanted. However, we'll discuss barriers, complications throughout this presentation. So I'll talk a little bit about the history of ABO incompatible kidney transplant. So the first case series was published in 1955 by Hume and colleagues. 8 of the 10 allografts were lost within the first few days post-transplant. And in the late 80s, Japan began utilizing organs from ABO incompatible donors more frequently. And then the US followed suit in the 90s, and then Europe in the early thousands. And then in 1987, the first series of successful ABO incompatible kidney transplants were described by Alexandre and colleagues out of Belgium. These were all performed using living donors and splenectomy. And the immunosuppression they used included steroids, cyclosporin, azathioprine, antithymocyte globulin, and donor-specific platelet transfusions. So currently, there is no data from the Organ Procurement and Transplantation Network or the Scientific Registry of Transplant Recipients to quantify the number of ABO incompatible kidney transplants that happen in the US annually. However, there was a published survey completed by Garanzik, Wayne, and colleagues from 2011 that aimed to quantify the number of centers that perform ABO incompatible kidney transplants. They received 125 responses, and the centers represented 67% of centers in the US and over 80% of the volume of living donor kidney transplants. So 30 centers, so about 24%, responded saying that they do perform ABO incompatible kidney transplants. However, there's still no data to exactly quantify how many are performed. The study did not assess how much each center individually does, so we still don't have a great idea. And then this data now being 12 years old, I'd be curious to see what the actual numbers are happening in the entire US. And then Asia and Europe have more published data in this field compared to the United States. This is due to other countries not utilizing deceased donors as frequently as we do here in the United States for a multitude of reasons. So a lot of donor characteristics that may be deemed inappropriate, different ethical considerations, religious influences, etc. They also may lack the infrastructure to create these large allocation systems like we have in the United States as well. So I'll talk a little bit about the pathophysiology. I'll discuss rejection, I'll discuss accommodation, and then also talk a little bit about tolerance. So first, I'll discuss the steps and mechanism of hyperacute rejection following ABO incompatible kidney transplant. So first, the complement system is activated as a result of the presence of existing antibodies or these isoglutenins in the recipient plasma against the graft. The complement pathway causes direct endothelial cell damage, and then this elicits an inflammatory response. Cytokines and chemokines attract cells of the innate and the adaptive immunity, and this further propagates the inflammatory processes, causing more and more damage. Antigen-presenting cells such as macrophages, dendritic cells, B cells are then held at the site of rejection on the graft directly by adhesion molecules. And then this adhesion begins to promote platelet aggregation. And this process can potentiate thrombosis and then ultimately lead to graft loss. And this reaction will begin within minutes of implantation. So now I'll go through the mechanisms again, but more in an easier way to understand with some graphics. So first, like I said, you have complement activation, which causes direct endothelial cell damage. And this will then lead to pro-inflammatory cytokines, neutrophils, but also macrophages and other cells being directly involved in the production of more inflammation and more damage. And then this leads to potentially thrombosis with platelet aggregation. And so now I'll discuss the phenomenon of accommodation. So this has been defined as the presence of circulating isoglutenins and antigens on the graft cells, but with normal renal function and normal histology. So the steps to accommodation are a lot less understood than that of the mechanisms of hyperacute rejection. So because accommodation is the presence of isoagglutinins and antigens, there will be complement-mediated damage. That damage is often characterized by the first step of accommodation, which coincides with this time frame of this early potential irreversible rejection that could occur. There is continuous ongoing damage and thus ongoing repair that creates a higher and higher threshold for lethal injury from the complement and phagocyte activation. So the early interaction of antibodies, complement, and phagocytes with the antigen target also increases the capacity of the immune system to repair the tissue. So overall, accommodation is this increased threshold for injury that may also be reflected by remodeling of blood vessels, other supporting structures nearby, and this allows the graft to remain functional despite this constant damage. This slide compares the timeline of hyperacute rejection and accommodation, which I think is very helpful in understanding not only the mechanisms, but also when you are clinically evaluating a patient, looking at symptoms or histology, you'll know at what time point certain processes are underway. So for hyperacute rejection, like I had said previously, will occur within minutes, and the severity of this rejection and damage is dependent on the desensitization that will occur pre-transplant. Early acute rejection can occur within weeks, and the risk of acute rejection will continue beyond this time frame, but will persist for the duration of the graft survival as well. And then on the other hand, the timeline for accommodation is based on the threshold for resistance and for repair. So the recipient will have a baseline threshold for resistance and damage to the graft, and this damage will induce more resistance, which will then increase the threshold for repair. So you will notice that the timeline for repair will start a few weeks post-transplant, and this is the time frame at which accommodation is achieved when the repair is underway. At the same time, the threshold for repair is increased. So therefore, accommodation is this balance of thresholds and repair and resistance to this ongoing damage that allows the graft to function in the presence of damage due to this complement-mediated destruction. Another popular topic in transplant immunology often discussed is tolerance. So I included this slide so we can compare and contrast tolerance and accommodation to make sure when we're looking at patients, we're able to correctly identify which immune processes are underway so we can better understand how that influences their immunosuppression. So tolerance reflects changes in the immune system. Tolerance avoids reactivity of the immune system with autologous cells or the recipient's own immune cells. Tolerance also requires specific non-responsiveness. So overall tolerance is reflective of a non-responsive immune system. Accommodation, on the other hand, is a direct alteration in the graft tissue itself. And this process allows the tissue to withstand damage that occurs because of an immune response and may incur a limited biological cost, like complement-mediated endothelial cell damage. However, that damage does not alter the function of the graft. So in other words, this is a byproduct of the immune system and its inflammatory processes. So now I'll talk about some evidence. So I'll talk about what we know up until this point, what therapy options are utilized currently. So for the evidence, I'll discuss isoglutenin titer quantification and then some therapy options, which centers may use all of or a combination of the following, including plasmapheresis, immunoglobulin use, B-cell depletion, and I'll briefly touch on maintenance immunosuppression. So isoglutenin quantification is the measurement of ABO antibody titers, and the number represents the number of dilutions that are performed while still having the ABO titers remaining present. So every center will have a specific goal for what they want their recipient's titer to be prior to proceeding with the transplant. So there are several different desensitization, preconditioning strategies that is center-based, which start days to weeks before transplant. Something to note is that when titers increase after transplant, we do not have evidence that suggests there might be an increased risk of antibody-mediated rejection when this happens. So this is something important to note because if clinicians see an increased titer post-transplant, there may be an inclination to increase or optimize the patient's immunosuppression when that may not be necessary if there's no change or decrease in allograft function.
She can look everywhere for her.
So this is from an ATC abstract that was presented in 2022 by and colleagues, and they presented data on 260 ABO incompatible kidney transplants. They distributed the patients based on what they deemed to be a high baseline titer and a low baseline titer prior to any desensitization. So the high titer group was defined as a pre-transplant titer of greater than or equal to 1 to 128, while the low titer group was defined as a titer of less than or equal to 1 to 64. All patients received rituximab, plasmapheresis, and IVIG. The high titer group required more sessions of plasmapheresis than the low titer group. And the high titer group also had persistently higher titers post-transplant than the low titer group. So when we look at the long-term outcomes between these groups, there was no statistical difference in rejection-free survival, graft survival, or patient survival. However, if you look at the top left graph representing infection-free survival, you will see that there was a significantly higher probability of survival in the low titer group. So this data gives us more insight to what the clinical implications are of high titers or low titers. Those with high titers may have a higher risk of infections, but the high titer group did not have an impact on rejection, graft survival, or patient survival. So this gives us a little bit more insight into what these titers may mean for our patients. So plasmapheresis is the mechanical removal of antibodies. So this is the largest way to reduce isoglutenin titers by that physical removal of ABO antibodies from the recipient's plasma. So there are different modalities of pheresis techniques that exist all across the world, most of which are not available in the United States. So for the purpose of this presentation, I'll only be discussing plasmapheresis. And the total number of sessions of plasmapheresis the patient will undergo will be dependent on how quickly the titers respond. Every center will have a different goal. The most common goal expressed in literature is equal to or less than 1 to 8 prior to proceeding with the transplant. So immunoglobulin or IVIG is used to reduce antibody rebound after transplant and therefore could potentially decrease the risk of AMR after an ABO incompatible kidney transplant. But then it will also replete immunoglobulin that is lost by the use of plasmapheresis as well. The most common administration in literature is 500 milligrams per kilogram per body weight on the day before transplant. However, this varies very widely based on center. Sometimes it's divided and given after each session of plasmapheresis, or sometimes it's given at the end of the last session of plasmapheresis. So now I'll be talking about B cell depletion and the different approaches taken to complete this. So prior to the early 2000s, the mainstay of B cell depletion was splenectomy. And then the use of anti-CD20 agents began to take the place of splenectomy. So on this slide is a timeline of some literature that we have. So one of the largest pieces of literature that utilized splenectomy was with plasmapheresis, and it was done by Takashi and colleagues, over 400 patients. And then in 2005, more use of anti-CD20 agents became popular, and Glor and colleagues published their experience of 11 patients with the use of plasmapheresis and IVIG. Also, Jenberg and colleagues published their experience with 15 patients using anti-CD20 agents in place of splenectomy in combination with immunoabsorption, which is a type of plasmapheresis. Like I had said previously, the first standard of care approach to B cell depletion in ABO incompatible kidney transplants was splenectomy, which then removes the memory B cells, but also naive B cells. And then rituximab began to take the place of splenectomy in many centers in the early 2000s. It's often referred to as a chemical splenectomy, as it hinders B cell immune response, but without the surgical complications and the procedure that accompanies splenectomy. So rituximab may also reduce isoagglutinin rebound post-transplant, so that may reduce the risk of antibody-mediated rejection. There's also discussed that potentially rituximab could decrease risk of chronic rejection down the line. However, that has not been fully elucidated in the literature as of yet. And in a meta-analysis that included over 4,800 ABO incompatible kidney transplant recipients, since 2000, 45% still underwent splenectomy, while 35% received rituximab. So 20% of patients in this meta-analysis did not receive any form of B cell depletion. So here are some outcomes from the meta-analysis I had mentioned of over 4,800 ABO incompatible kidney transplant recipients. They separated those based on who received rituximab versus who underwent splenectomy. The authors did a subgroup analysis, and regardless of what preconditioning the patient received, there was a significantly longer graft survival and patient survival after 2006. So patient survival for all groups was greater than 90% at a mean time follow-up of 28 months, but there was numerically higher survival in the rituximab groups, and survival after 2006 was increased in both groups. So graft survival in splenectomy group before 2006 was pretty low at 73%, but then improved to almost 85% after 2006 at median time of 28 months. And rituximab had a higher graft survival of 83% before 2006, which then increased to 95% after 2006 at the same mean follow-up time. So overall, rituximab appears to be a safe and effective alternative to splenectomy for B cell depletion in these patients. So this is an example of a protocol that is based off of isoglutamine titers and what immunosuppression the patient will receive, both pre-transplant, on induction, and for maintenance immunosuppression. So this is a representation of a common approach to desensitization, and this is a specific protocol utilized by Barnett and colleagues, which is a group out of London, and their titer goal is less than or equal to 8. So those will receive rituximab if the titer is 8 or higher. And then if the titer is 16 or higher, they also receive double filtration plasmapheresis. And if the titer is 64 or above, they underwent immunoabsorption in addition to rituximab. So all patients received basiliximab and methylprednisolone for induction. All patients received tacrolimus, mycophenolate, and prednisone for maintenance immunosuppression. So this group compared 62 ABO incompatible kidney transplant recipients to 167 ABO compatible transplant recipients. They looked at differences in rejection, graft survival, and patient survival. So I'll be showing you those. This graph represents the number of patients remaining free of rejection at the end of 1 year. And at 1 year, there was no difference in the number of patients who were free from rejection, regardless of if they underwent an ABO compatible or ABO incompatible kidney transplant. So now when we're comparing allograft survival between these groups, there was no difference between the ABO incompatible and the ABO compatible graft survival. And this was at 3 years post-transplant. And then patient survival is represented by this graph. So at both 1 and 3 years, there was a significantly higher number of patients who survived in the ABO compatible group compared to the ABO incompatible group. So the first separation you see here in this graph occurs just prior to the 1 year mark, which has been consistent with some other literature as well, that mortality within the first year has been a very significant endpoint to look at. And here shows that the 1 year post ABO incompatible kidney transplants was significantly higher than those undergoing ABO compatible kidney transplant. And of the recipients who died in this trial, all were due to infectious complications. So 3 cases were due to pneumocystis pneumonia. They did not comment on if these patients received prophylaxis, with what agent, and for how long. And then in the ABO compatible group, those who died were due to cardiovascular causes or malignancy causes. So this should caution providers and clinicians regarding infectious risk of patients undergoing desensitization protocols and undergoing ABO incompatible kidney transplants. So Ma and colleagues are a group out of China that recently published this review article in 2023 based on all the data that has been published up until this point. And they offer a recommendation for the optimal desensitization, induction, and maintenance immunosuppression for ABO incompatible kidney transplants. However, there are no results associated with this paper. It's only a recommendation based on previous literature. So they do recommend giving rituximab 14 days pre-transplant and then starting maintenance immunosuppression with tacrolimus and mycophenolate 10 days pre-transplant. They recommend methylprednisolone and basiliximab for induction immunosuppression. And based on their isoglutamine titers, they recommend plasma exchange or double filtration plasmapheresis to reach a titer of less than or equal to 1 to 8. So now I'll be presenting some data from a meta-analysis that was published in 2023 that comprised of 15 studies, most of which were out of Asia. However, there was some data included from the United States, Europe, and Australia. So they looked at patient survival, graft survival, and safety outcomes. The statistics used in this meta-analysis were I2 statistics, so they were looking at the heterogeneity between the studies included. So the short-term survival, which was 94%, which sounds promising. However, it was not heterogeneous across all studies and was therefore deemed not statistically significant. However, there was heterogeneity in the long-term patient survival of 3 years post-transplant with a rate of 93%. And when we look at graft survival at both 1 and 3 years, there was heterogeneity between the studies with short-term and with long-term graft survival occurring at 94% and 89% respectively. Then for safety, the rate of infection was 31%, surgical complications 12%, and then medical complications of 38%, which were all heterogeneous across the studies. So this further illustrates the caution providers, clinicians should have when preparing a patient for ABO incompatible kidney transplant due to the rate of infectious, surgical, and medical complications that could occur. So now just for completeness, I'll briefly touch on maintenance considerations. So there have been a few publications out of Europe that evaluate the potential for steroid withdrawal in ABO incompatible kidney transplants. However, Wang and colleagues from Indiana evaluated the ability to withdraw steroids, which may lead to an increased risk of acute rejection after withdrawal. And ultimately, the consensus from them and from other literature and most centers is the assumption that ABO incompatible kidney transplant recipients should not be withdrawn from steroids or have their maintenance immunosuppression reduced. So now I'll talk a little bit about the innovation and the future of ABO incompatible kidney transplant. So there are some publications that evaluate single center experiences using eculizumab and ABO incompatible kidney transplantation. These are both single center experiences by Wes Thielke and colleagues at University of Illinois Chicago and Hiegler and colleagues from University of Illinois Chicago. First, in 2018, Wes Thielke published a case of 4 patients that were treated with a 9-week course of eculizumab without any plasmapheresis, IVIG, splenectomy, or any B-cell depletion. All patients had successful allograft function without any cases of AMR or acute cellular rejection. And 2 patients did have titers of 1 to 32 pre-transplant, which at any other center, any other published protocol would be considered a contraindication to proceed with the transplant. As more literature came out about the phenomenon of accommodation, the time frame at which accommodation is thought to occur, Hiegler and colleagues submitted early outcomes of 9 patients who underwent ABO incompatible kidney transplants with only 1 dose of eculizumab. This was done in combination with thymoglobulin, tacrolimus, mycophenolate, and a 1-month prednisone taper down to prednisone 10 milligrams daily. There was no plasmapheresis or B-cell depletion used in this protocol either. 8 patients had no rejection and had excellent allograft function. 1 patient did have AMR after they had subtherapeutic tacrolimus levels. 2 weeks post-transplant, they eventually recovered, however, with reduced renal function. So now I'll outline a few characteristics from the second paper, the Hiegler paper. So the baseline titers for 7 of the patients were higher than what would be considered appropriate to proceed with transplant by any other protocol or by any other center. The post-op titers ranged pretty widely. So some patients increased, some decreased post-transplant. They looked at complement activity, was measured using CH50 test, but did not guide any clinical management. It was more for academic purposes than anything else to see if there was a clinical correlation between complement activity and allograft function after using eculizumab. 1 patient did have AMR, like I had mentioned, and they did receive treatment and recovered with worsened renal function. And then when we look at infectious outcomes, 5 patients had at least 1 UTI post-transplant. There was 1 case each of a wound infection, COVID-19, bloodstream infection with concomitant pyelonephritis, and C. diff, none of which resulted in mortality at a mean follow-up time of 6 months post-transplant. So these studies show potential. There may be some utility of using eculizumab in ABO incompatible kidney transplantation without the need for B-cell depletion with splenectomy or rituximab or plasmapheresis and IVIG. So another emerging innovation is measuring CD19 ratios among B cells. So this is an ATC abstract from 2018 published by Unagami and colleagues out of Japan. They measured the ratio of CD19 B cells among 127 ABO incompatible kidney transplant recipients after they received preconditioning with rituximab therapy prior to transplant. And graph A shows that they noted a significant difference in those who had CD19 positivity of 2% or greater as the potential predictor of AMR following an ABO incompatible kidney transplant. Graph B is showing those who had AMR based on those with and without DSA, which served as a control group for graph C, which showed that in DSA negative patients, CD19 positivity remained a positive predictor for AMR. In graph D, they showed the ratio of CD19 positivity. It was also noted as a possible predictive for AMR in those with negative DSA and an HLA-DR mismatch less than 2. So this is promising data that suggests monitoring CD19 positivity pre-transplant may assist in the prediction in patients undergoing ABO compatible kidney transplant and could therefore potentially future assist in guidance of immunosuppression. So another innovation in progress is this novel technology in immunology. So Peter Raffeld, which is the chief scientific officer of a company called ABO Zymes, presented plenary at ATC last year about their novel technology and its future potential. So this is a British Columbia-based team owned by AVivo, and they have identified enzymes that convert the ABO cell surface antigen to blood group O. So the goal of this technology is to make ABO groups essentially obsolete for the need for blood transfusions, but also for organ transplantation. So this could lead to increased utilization of what would previously be incompatible organs and reduce logistical considerations as well. So they have published case reports utilizing these enzymes on several sets of lungs, which were converted from blood group A to group O during ex vivo lung perfusion. So another piece of this ABO incompatible puzzle is the financial considerations. So in 2006, Schwartz and colleagues published a cost comparison between ABO incompatible and ABO compatible kidney transplant recipients between 1999 and 2003 at Mayo Clinic. There were more surgical related complications, more resources utilized in the ABO incompatible group, mostly related to the desensitization protocols and AMR treatment. Overall, the number of complications were similar between groups. ABO incompatible kidney transplants were $38,000 more expensive. However, this was still deemed to be more cost-effective than maintaining a patient on hemodialysis waiting for a compatible deceased donor offer. This data is also from 2006, so I'd be curious to see how different these costs would be now in 2024. When we think about the future of ABO incompatible kidney transplant, the cost of new therapies like eculizumab could significantly increase the drug cost of ABO incompatible kidney transplant. Even with 340B pricing, the cost of one dose of eculizumab is over $15,000. So, however, that could potentially remove the need for plasmapheresis or other desensitizing strategies. So I'd be curious to see what the newer financial implications would be in this year. So in summary, ABO incompatible kidney transplants offer a potential increase in the utilization of living donors. However, there's no consensus on the ideal desensitization, immunosuppression regimen for patients undergoing these transplants. There are significant risks associated with ABO incompatible kidney transplants, including the increased risk of infection, complications. So that should be weighed against the potential benefit in all of our patients. So when providers are evaluating candidates for ABO incompatible kidney transplants, they should be selected on a patient-by-patient basis that takes into account infectious risk, immunosuppression, desensitization, in order to optimize the patient's outcome. So I have some supplemental resources here. The first two are review articles that outline a lot of the history and the background of ABO incompatible kidney transplant. And then the last is the most recent and largest meta-analysis that I presented some data on, if you'd like to review some of the newest data for yourself. So with that, I will take any questions that you guys may have.
Thank you so much, Rachel. I don't see any questions in the chat just yet. So just a reminder to anyone to feel free to type those in. In the meantime, I just have a question regarding how successful your center has been with obtaining insurance coverage for the eculizumab.
Yeah, so we have been submitting prior authorizations for eculizumab, usually using indication as rejection for most of our patients. It's been successful, and from what I've seen, at least this year, maybe in about 60 to 70% of patients. And if possible, we administer the dose outpatient in our infusion clinic. Currently, our protocol is using 2 doses of eculizumab. So we use one post-op day -1, and then we use another usually between post-op day 5 and 7. And if they're still in the hospital, but we can give it to them outpatient, we'll try to give them outpatient instead of giving it to them in the hospital.
Excellent. Makes a lot of sense, and that's good to hear. 60 to 70% seems pretty good to me. I'm sure we all would like it to be 100, but
Yeah.
we certainly have challenges at my institution. All right. I'm still not seeing any questions in the chat. One final reminder that we will be sending out instructions to register for the Rush CE kind of program to obtain your CE credit, as well as the link to get today's CE credit at some point later tonight or tomorrow after the presentation. And we will be posting the recording of this webinar on our ACCP Transplant PRN YouTube page once the CE credit window is complete, which takes 10 days after the presentation. But thank you again so much to Dr. Christensen for her willingness to present to our PRN, and I hope you all have a great rest of the day.